behavioral disorder in children prepared by Dr. Birhanu, Pediatrics and Child Health Resident, October 2021. The followings are the outline of the presentation, and thank you to be with me. Objective definition of behavioral disorder, categorization of behavioral problem, assessment of behavioral disorders, common behavioral disorder recommendation. The reference I used for the presentation are primary from Kleekman, Nelson Textbook of Pediatrics 21 edition, chapter 32 to 54 and 2021 up to date. And some contents are taken from Kaplan and Sadok's Pocket Handbook of Clinical Psychiatry 6th edition. After the session you would able to know about common behavioral disorders in childhood, types, causes, diagnostic criteria with diagnostic and statistical manual 5, management of selected childhood behavioral disorders. Introduction on behavioral disorder. When a behavioral disorder is considered in children, personas COPPOSITIONAL behavioral disorder different from expected, not doing what adults want, todo cannot adjust to a complex environment, unable to behave in the socially acceptable way. Classification. Behavioral disorder are based on age and nature of the disorder, categorized into spontaneous responsive, non-spontaneous responsive, also classified according to the settings. Behavioral disorder. Most common behavioral disorder are respectively from highest to lowest prevalence are language problems, behavior or emotional disorders, attention deficit hyperactivity disorder, learning disabilities less common and more disabling disorder, intellectual disabilities account 1 to 2%, autism spectrum disorders in 1 of 59 children, cerebral palsy and related motor impairments accounts 0.3%, hearing impairment. Causes of behavioral disorder are classified as 1. Heredity, 2. Environment and example of environmental causes are like poor economy, mass media, changing lifestyle and urbanization. 3. Physical and mentally sick or handicapped condition like unhealthy relationship, lack of discipline, change in moral standards and value. 11. Mental health action signs are: first is feeling very sad or withdrawn for more than 2 weeks. Second is seriously trying to harm or kill yourself, or making plans to do so. Third is sudden overwhelming fear for no reason, sometimes with a racing heart or fast breathing. Fourth, involvement in many fights, using a weapon, or wanting to badly hurt others. Severe out of control behavior that can hurt yourself or others. Not eating, throwing up, or using laxatives to make yourself lose weight. Intense worries or fears that get in the way of your daily activities. Extreme difficulty in concentrating or staying still that puts you in physical danger or causes school failure. Repeated use of drugs or alcohol. Severe mood swings that cause problems in relationships. And the 11th is drastic changes in your behavior or personality. Rapid psychosocial assessment screening interview. For taking a rapid psychosocial history, parent interview is abbreviated as HEDSAS, which is mnemonic for home. How well does the family get along with each other? Education. How well does your child do in school? Activities. What does your child like to do? Does your child do anything that has you really concerned? How does your child get along with peers? Drugs. Has your child used drugs or alcohol? Sexuality. Are there any issues regarding sexuality or sexual activity that are of concern to you? Suicide/depression. Has your child ever been treated for an emotional problem? Has your child ever intentionally tried to hurt him/herself or made threats to others? Screening tools. Psychiatric screening checklists. Strength and difficulty question. Scared. Self-report for child-related emotional disorders. Vanderbilt ADHD Diagnostic Rating Scale Modified Checklist for Autism in Toddlers. Center of Epidemiological Survey. Depression Scale. Mood and Feelings Questionnaire. Short version. Standardized screening instruments like ages and stages questionnaires. Brief infant toddler social and emotional assessment. Early childhood screening assessment. Modified checklist for autism in toddlers, parents' evaluation of developmental status, and survey of well-being of young children designed for this age group can be helpful in systematizing the evaluation. Common behaviors in children. Infant common behavioral problems: abdominal colic, resistance to feeding, stranger anxiety. Children common behavioral problems: emotional problems, stereotypic movement disorder, elimination disorder, speech problems, sleep problems. Adolescent common behavioral problems: eating disorder, sexual problems, delinquency. Colic, benign or self-limited condition. Crying or fussiness is present in all babies. Medical attention in about 20%. Diagnostic criteria: an infant who is less than 5 months of age, recurrent and prolonged periods of infant crying, fussing, or irritability without obvious cause and not prevented. No failure to thrive. Fever or illness. It is diagnosed with Wessel criteria, that is rule of 3, beginning in the second or third week of life, lasts about 3 hours a day, occurs 3 days per week, lasts for more than 3 weeks, resolves by 3 or 4 months of age. Proposed etiologies of infant colic: gastrointestinal disturbance, faulty feeding techniques, underfeeding, overfeeding, infrequent burping and swallowing, air, cow's milk, protein intolerance, allergy, hydrolysata formulas, hypoallergenic diet, lactose intolerance, gastrointestinal immaturity. Excessive gas is produced when the unabsorbed carbohydrate is fermentation. Intestinal hypermotility, alterations in fecal microflora. Proposed etiologies of infant colic: first one is biologic causes due, like immature motor regulation, increased vulnerability to feeding, intolerance, increased serotonin, tobacco smoke and nicotine exposure. Secondly, psychosocial theories. Colic is a psychosocial phenomenon: caretakers' perception of what is excessive and prolonged temperament, overstimulation and parental variables, family stress, maternal anxiety and transmission of tension from mother to infant. So now let us see on clinical features of infantile colic. Paroxysmal colic: qualitative differences in coli. Physical characteristics like facial flushing, tense or distended abdomen, drawing up of the legs, clenching of the fingers and tightening of the arms, arching of the back, difficulty consoling the infant, and sometimes relief may be noted. Management is to decrease crying and bolster the infant-family relationship and parental support, confirming the diagnosis, reassurance, and advise to take breaks from the crying infant. Parental education by telling as the condition is common and usually resolves spontaneously, not caused by something they are doing or not doing. Feeding technique. Soothing techniques are important in colic management by decreasing sensory stimulation, taking the infant for a ride in the car or a walk, rocking and swing infant, changing the scenery infant, providing a warm bath, rubbing abdomen, playing an audio tape, providing white noise generators. The above technique can be used in any order or combination. Try a technique for several minutes. Dietary changes. Trial of dietary interventions: breastfed infants, maternal milk product consumption, or a hypoallergenic maternal diet. Look sign of allergy. Option 4, formula-fed infants with colic: extensive hydrolysate formula like Alimentum, Nutramigen, Brigestimil. Continued. If there is a decrease in fussiness, response usually occurs within 48 hours. Original formula is resumed. If there is no change, soy protein formula, fiber-enriched formula. Other option of management are using probiotics from Lactobacillus reuteri, not for routine management because of its costs. Simethicone causes gas bubbles to coalesce, facilitating expulsion. Safe, but it may interact with levothyroxine. Herbal remedies like herbal teas, fennel seed, gripe water. Follow-up: individualized re-examination to be reassured. Referral for parents who are extremely anxious. Outcomes: parents of colicky infants experience stress, fatigue, guilt, and depression. Another common childhood behavioral disorder is disruptive, impulse control, and conduct disorders. These are interrelated sets of psychiatric symptoms characterized by a core deficit in self-regulation, anger, aggression, defiance, and antisocial behaviors include oppositional, defiant, intermittent, explosive conduct, other specified/unspecified, disruptive/impulse control/conduct, antisocial personality disorders, oppositional defiant disorder, angry, irritable mood, argumentative/defiant behavior or vindictiveness exhibited during interaction with at least one individual lasting at least 6 months. For preschool children must occur on most days. In school-age children must occur at least once a week. Severity is based on setting: mild, moderate, and severe. Etiology and risk factors in oppositional defiant disorder: number of neurobiologic markers, peri, and postnatal insults, reduced basal cortisol reactivity, serotonergic abnormalities, parents of behaviorally disordered children, negative parenting responses, impaired parent-child attachment, child maltreatment, family poverty and crime, peer level influence and neighborhood influences. Diagnostic criteria for oppositional defiant disorder are at least 6 MOAs evidence, at least 4 symptoms: first, angry or irritably mood, angry temper, often easily annoyed; second, argumentative or defiant behavior, wayne actively defies or refuses to comply, deliberately annoys others, blames others, argues; third, vindictiveness, spiteful or vindictive or associated with the stress or impacts negatively. No exclusive liger and gap, psychotic substancers, depressive or bipolar disorder. Conduct disorder is characterized by a repetitive and persistent pattern, at least 12 months of serious rule-violating behavior. The symptoms of CD are divided into 4 major categories: aggression to people and animals, destruction of property, deceitfulness or theft, serious rule violations. 3 subtypes based on the age of onset: childhood onset type, adolescent onset type, unspecified based on severity classification, number of symptoms and impacts: mild, moderate, and severe. Clinical course of conduct disorder: the prevalence is approximately 3%, prevalence rate of CD higher in adolescence than childhood. Males lower socioeconomic classes becomes a concern if it is intense, persistent, and pervasive, affects the child's social, family, and academic life. Earliest manifestations of oppositionality are stubbornness, defiance, and temper tantrums. Argumentativeness: approximately 65% of children exit from the diagnosis after a 3-year of follow-up. Age at onset is an indicator of prognosis. Approximately 30% with comorbid ADHD increases risk for depressive and anxiety disorders. Parent training programs in conduct disorder: specific parent training programs, parent-child interaction therapy helping non-compliant child, parent management training. Predictors of non-response to interventions are initial symptom severity, involvement of parent, premature termination. LT5 treatment sessions is high as 50-60%. Predictors of premature termination of parent training programs are the following: first, single parent; the second one is family income; third is parental education levels, and the fourth is the maternal age. Cognitive behavioral therapy in conduct disorder delivered in multiple sessions and multidimensional treatment is needed. School-based behavioral interventions, youth anger management, problem-solving training, family therapy, psychiatric consultation, medical management. Methylphenidate: average dose for methylphenidate approximately 1 mg per kg per day. And second, medical management is with atypical antipsychotic like risperidone are used and helps in reducing aggression and conduct problems in children age 5 to 18 year. Usual daily dose of risperidone for severe aggression 1 to 2 mg for children, 2 to 4 mg for adolescents. Duration of trials is 6 to 8 weeks. For atypical antipsychotics have strong evidence for the management. Predictors of non-response are higher rule-breaking behavior and presence of comorbid mood disorders, squeal in disruptive, impulse control, and conduct suicidal behavior, physical injury, delinquency and criminality, legal problems, substance use, unplanned Pregnancy, social instability, and marital failure are the common squeal. Other common childhood behavioral disorder is tantrums. What is tantrums? It is a sudden outburst, anger, frustration, and bad temper, physical aggression or resistance manifested with rigid body, biting, kicking, throwing objects, hitting, crying, rolling on floor, screaming loudly, and banging. Common during the first few years of life, averted by a parent's awareness or attunement to certain cues. Advised that parents plan to be aware of triggers and minimizing the trigger. What is breath-holding spells? Reflexive events occur during a tantrum from 6 months to 6 years of age. May lose consciousness and occasionally will have a brief seizure. Parents are best advised to ignore it. Generally without reinforcement disappears. Subtypes: cyanotic, pallid, and mixed episodes. Iron deficiency may be present. May respond to iron therapy. No increased risk of seizure disorders. Medical conditions should be ruled out. Management professional help from child guidance. A clinic parent should be made aware about the beginning of temper tantrum and when the child loses control. Nobody's who'd make punanti as the child. Parents should model the anger control. Parents angry worsen the problem. Providing choice enhancing the parent-child relationship. Building problem solving skills. Referral for a mental health evaluation. Not respond to parent coaching. Head banging or high levels of aggression. Lying. Why lying? For children 2 to 4 years, a form of fantasy for children or a method of playing with language to avoid an unpleasant confrontation. Means not permit the realization. Rarely malicious or premeditated. Why lying? In older children, temporary good feeling and to protect against a loss of self-esteem. To avoid a negative consequence for misbehavior. Habitual lying can also be promoted by poor adult modeling to avoid adults' disapproval. Chronic lying can occur in combination with antisocial behaviors, a sign of underlying psychopathology. Habitual lying. Stealing. Many children steal something at some point in their lives as an action to acquire something they want, like candy or a toy from the store shelf. Can be an expression of anger if noticed. It is a teaching opportunity. Frequent stealing may be a response to stressful environmental circumstances. Further exploration and evaluation can be learned from adult survival mechanism like youth living in poverty. It is important for parents to help the child undo the theft when stealing is part of a pattern of broader conduct problems. Referral for a mental health evaluation is warranted. Truancy. Disorganization within the home, caretaking needs of younger siblings, developing conduct problems, or emotional problems. More common in older children. Never developmentally appropriate causes. Learning difficulties, social anxiety, traumatic exposure, peer pressure, substance use. Best practices. Addressing underlying causes, empowering family. High risk for substance abuse, unsafe sexual activity, and other risk-taking behaviors. Never developmentally and should be referred. Habits involve repeated action or pattern of behavior common in childhood and range from usually benign and transient behaviors more problematic in DSM-5. Habits are not included as a diagnostic category, not viewed as disorders causing clinically significant distress or impairment. Common habit disorders benign like thumb sucking and nail biting, and problematic as bruxism and trichotillomania. Thumb-sucking common in infancy. Beyond 5 years may be associated with squeal-like abnormality of teeth as shown in the picture. Difficulty in mastication and swallowing. Deformity of tongue. Facial distortion. Speech difficulties with consonants. GI infections. Management of thumb-sucking includes support and advised distraction, simple reminders and reinforcers, mechanical devices, consultation, hygienic measures, praising and encouraging parents, nature reassurance. Bruxism. Teeth grinding is common. 5 to 30% of children can begin in the first 5 years of life. Associated with daytime anxiety. Persistent bruxism can manifest muscular or temporomandibular joint pain. Dental occlusion associated with anxiety. Reduce anxiety might relieve the problem relaxing by reading or talking or allowing for discussion, praise and other emotional support. Persistent bruxism requires referral. Takes brief, sudden, rapid, repetitive movements of striated muscles, mainly obtufation, nechitis, outl, tough, suppressidang, worry for control of aggression. Characterized by multiple motor tics and focal tics. Motor tics example are eye blinking, grimacing, shrugging, shoulder, tongue protrusion, facial gesture. Vocal tics examples are throat clearing, coughing, barking, sniffing. Self-stimulating behavior in response to tension and anxiety of in school children may occur in deep sleep. Enuresis, repetitive involuntary passage of urine at inappropriate place, especially in bed, beyond the age of 4 to 5 years, and 3 to 10% school children occurs twice weekly for at least 3 months at age of 5 years. 7% for males and 3% for females. Classified as persistent or primary or aggressive or secondary. Physiological: bladder capacity, psychological: deep sleep, small bladder capacity, psychological: dominant parent or punishment, sibling rivalry, toilet at distance from room, hostile dependent parent-child relationship, emotional deprivation due to insecurity and parental death, dark passage in a toilet or cold or fear of toilets, organic spinal bifida, neurologic bladder, juvenile DM, seizure disorders, monosymptomatic enuresis and non-monosymptomatic enuresis. Management of enuresis: behavioral therapy, environmental modification, restriction of fluid after dinner, voiding before bedtime, interruption of sleep before the expected time of bed, wetting, fully waken up with parent and meta worry, missing of urine, night responsibility for changing bed clothes, encourage introvert the chilled for 3 nights, bladder exercise and electric alarm bell device, and safest method. Punishment and criticism may lead to embarrassment. Pharmacologic like tricyclic antidepressant, imipramine. Encopresis: voluntary or involuntary passage of feces into inappropriate places at least once per month for 3 consecutive months. Once a chronologic age of 4 years. Subtypes include retentive encopresis with constipation and overflow incontinence representing 65 to 95%, non-retentive encopresis without constipation and overflow incontinence. Primary or secondary associated problems on encopresis are chronic constipation, parental overconcern, overaggressive toilet training, toilet fear, attention deficit disorders. Management of behavioral techniques: regular bowel habit and training, dietary intake, parental support, medical management, impaction and anal fissures, psychologist, child and parents reassurance and counseling. Attention deficit disorders with 2 categories of core symptoms: inattention and hyperactivity/impulsivity. Predisposing factors: birth complication, dietary influences, iron and zinc, drug exposure and lead poisoning. Structural and functional differences: interaction between genetic and psychosocial factors. For children, LT1 7 years, needs greater than or equal to 6 symptoms. For adolescents, greater than or equal to 17 years, and adults, needs greater than or equal to 5 symptoms. Affect cognitive, academic, behavioral, emotional, and social functioning. Symptoms of inattention: failure to provide close attention to detail, difficulty maintaining attention in play, school, or home activities, seems not to listen, fails to follow through, difficulty organizing tasks, activities, and belongings, avoids tasks that require consistent mental effort, loses objects required for tasks or activities, easily distracted by irrelevant stimuli, forgetfulness and routine activities. Symptoms of hyperactivity and impulsivity: difficulty remaining seated when sitting, excessive fidgetiness, feelings of restlessness or inappropriate running, difficulty playing quietly, difficult to keep up with, seeming to always be on the go, excessive talking, difficulty waiting turns, blurting out answers too quickly, interruption or intrusion of others. The subtype of ADHD in a given patient can change from one to another over time. 1. Predominantly inattentive. Symptoms of inattention. 2. Predominantly hyperactive, impulsive. Symptoms of hyperactivity, impulsivity. 3. Combined. Symptoms of inattention and hyperactivity, impulsivity. Management classified by depending upon the predominant symptoms. Management done by team approach: pharmacological stimulants, drug holiday, non-pharmacological behavioral therapy, behavior modification, counseling, and guidance of parents, appropriate trained education of child, cognitive behavioral therapy, and biofeedback. Communication disorder. Communication requires the interaction of an intact mechanism: hearing, sensitivity, perception, intelligence, structural integrity, motor skill, and emotional stability. Children learn language in early childhood. Later they use language to learn. Developmental language disorder: impairment in the ability to receive, send, process, and comprehend concepts or verbal, nonverbal, and graphic symbol systems. Most common developmental disability of childhood occurring in 5 to 10% of children. Increased risk for difficulty with reading and written language often persist through adolescence or adulthood. Early intervention minimize more serious consequences. Speech disorder. Articulation disorder. The ability to produce speech sounds increases with age. Most children with disordered articulation and phonology do not exhibit an identifiable physical reason for the problem. Fluency disorder. Stuttering. Interruption in the flow of speaking due atypical rate, rhythm, and repetitions begin between the age of 2 to 5 years and more common in males. Etiology of stuttering is not completely understood, can be developmental, acquired, and psychological. Inability to adjust with environment and emotional stress. Voice disorder. Vocal quality, pitch, loudness, resonance, or duration. Speech problems. CONT. Hearing impairment. Have difficulty with all parameters of speech, not just articulation, result from a limited ability to hear others and to monitor their own speech production. Neurologic problems. Dysarthria, caused by neuromuscular impairment, inability in handling secretions, regurgitation, and recurrent URT and pneumonia. Apraxia, an impairment in the ability to program the speech musculature to select, plan, organize, and initiate a motor pattern it is presumed to be. Neurologic in origin. The validity of considering developmental apraxia of speech or developmental verbal dyspraxia as a separate diagnostic category is one of the most controversial issues in clinical speech pathology. Structural defects: cleft lip and palate, ankyloglossia, tongue tie, and complete or partial. Language disorders: apprehension or use of spoken, written, or symbol systems characterized by persistent difficulties in the acquisition and use of language, expressive or receptive deficits in comprehension or production. Spoken, written, sign language, reduced vocabulary, limited sentence structure, and impairments in discourse resulting in functional limitations. Ineffective communication, social participation, academic achievement, occupational performance. Phobia: fear of going to school. Emotional disorder of a children who are afraid to leave the parents. Symptom of crisis situation of developmental stages: recurrent compliant like abdominal pain. Headache subsides if allowed to remain at home. Contributing factors: anxiety, intellectual disability. School environment management: improve school environment, play session and recreational activities. Family counseling assesses health status. Eating disorders, overvaluation of a thin body and dysfunctional weight control behaviors usually affecting white and adolescent females. Persistent disturbance of eating include anorexia nervosa, avoidant/restrictive food intake disorder, binge eating disorder/bulimia nervosa, rumination disorder. Screening for ED using SCOFF, which consists of 5 clinician-administered questions. Do you make yourself sick because you feel uncomfortably full? Do you worry you have lost control over how much you eat? Have you recently lost more than 1 stone, 14 pounds or 6.35 kilograms, in a 3-month period? Do you believe yourself to be fat when others say you are too thin? Would you say that food dominates your life? A yes to 2 or more questions was associated with a sensitivity and specificity 187.5% for the diagnosis of an ED. Anorexia nervosa, refusal of food to maintain normal body weight by reducing food intake, especially fats, and carbohydrates. Practice vigorous exercises for weighing introduction or induce vomiting by stimulating gag reflex to maintain slim. Involves significant overestimation of body size and shape, with a relentless pursuit of thinness. Restrictive subtype combines excessive dieting and compulsive exercising. Binge purge subtype, overeat and vomiting or taking laxatives. A specific cause for anorexia nervosa. Anorectic parents and conflict in relationship may have associated conditions like ADHD, soft liver, kidney, heart or diabetes. Parent soft affected adolescent may be anorectic and having conflict in relationship with the children, overprotective, which lead to development of immaturity, isolation and excessive dependence. Diagnostic for anorexia nervosa. First is significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Second is intense fear of gaining weight or of becoming fat, or persistent behavior. Third is disturbance in which one's body weight or shape is experienced. Undue influence of body weight or shape on self-evaluation, or persistent lack of recognition of the seriousness of current low body weight. Specify in partial remission or in full remission. Specify severity. BMI. Specify current severity: mild. BMI greater than or equal to 17 kg/m2 moderate. BMI 16 to 16.99 kg/m2 severe. BMI 15 to 15.99 kg/m2 extreme, less than 15 kg/m2 systemic manifestation like undernutrition, marked weight loss, bizarre food intake patterns, dryness of skin, hypothermia, hypotension, bradycardia, amenorrhea, constipation. Avoidant or restrictive food intake disorder, lack of interest in food, the sensory characteristics of food, or a conditioned negative response associated with food intake. The eating behavior leads to a persistent failure to meet nutritional or energy needs, manifested by at least one of the following: clinically significant weight loss, or in children, or growth, or failure to achieve expected weight gain. Nutritional deficiency, supplementary enteral feeding or oral nutritional supplements are required to provide adequate intake. Impaired psychosocial functioning, not due to lack of available food or associated with a culturally practice, does not occur solely in the course of anorexia nervosa or bulimia nervosa. Binge eating episodes are marked by at least 3 of the following: rapidly than normal until feeling uncomfortably full, large amounts of food when not feeling physically hungry, eating alone because of embarrassment by the amount of food consumed, feeling disgusted with oneself, depressed, or guilty after overeating. Episodes occur on average at least once a week for 3 months. No regular use of inappropriate compensatory behaviors, example like purging, fasting, or excessive exercise. as are seen in bulimia nervosa, does not occur solely during the course of bulimia nervosa or anorexia nervosa. Severity is based upon the number of binge eating episodes per week. Mild is 1 to 3 episodes per week, moderate from 4 to 7, severe 8 to 13, extreme 14 or more episodes per week. Pica repeated eating of non-food substances for at least 1 month. Geophagia, pagophagia, xylophagia, trichophagia, urophagia, and coprophagia. It may be due to parental neglect, poor attention of caregiver, nutritional deficiency, itis common, poor socioeconomic family, malnourished children, and mentally subnormal. Both sex equally resolves spontaneously unless mentally disabled. Rumination disorder, repeated regurgitation and re-chewing and re-swallowing for at least 1 month, not due to a general medical condition or during the course of EDs, occur between 3 to 12 months and common in males. Behavioral intervention like lemon in juice and drugs. Management of eating disorder, advice on irrelevant to weight loss, not to blame parents for eating disorders. Reinforcement of parents' dialectical behavioral therapy, in which distorted thoughts and emotional responses are challenged, analyzed, and replaced with healthier ones, with an emphasis on mindfulness. Requires adult thinking skills and is useful for older patients, either in group therapy or combining patients at various levels of recovery. Recommendation: diagnose common behavioral problems in children, start management early, referral to psychiatric specialty clinic accordingly, and finally I recommend researcher to conduct a study on its magnitude. Thank you. This are the used for the presentation. Reference: Robert M. Kleekman, Nelson Textbook of Pediatrics 21 edition, Chapter 325422021. Up to date. www.uptodate.com. Sartorius N. The ICD-10 Classification of Mental and Behavioral Disorders, Clinical Descriptions and Diagnostic Guidelines, World Health Organization, Geneva 1992. ISBN 924154,422-8. Benjamin J. Kaplan and Sadok's Pocket Handbook of Clinical Psychiatry 6th edition, Newark 2019 Y-NFIMD. Prevalence of mental and behavioral